Good morning, students. Today the discussion topic is about drugs for inflammatory bowel disease. So in the previous class of diarrhea I have mentioned few drugs which are used in inflammatory bowel diseases, and the main symptom of inflammatory bowel disease will be diarrhea. That's why I have just mentioned the names when I discussed the diarrheal class. So today we will be seeing in detail of this inflammatory bowel disease. So in the previous class I have told that inflammatory bowel diseases are like a chronic disease and mainly immune mediated. So what is inflammatory bowel disease? And today's class will be discussed under headings like introduction, epidemiology, etiology, pathogenesis, clinical features, and so as an introduction, what is inflammatory bowel diseases? It is a chronic, remittent and progressive disorder of GAT characterized by inflammation of intestine resulting in abdominal cramps and persistent diarrhea. So it is a chronic, remittent and progressive disorder which has symptoms like abdominal cramps and persistent diarrhea. And out of that, the most common disease is ulcerative colitis and Crohn's disease. So in epidemiology, the higher incidence is seen in countries like Europe, United Kingdom and North America. And also when we talk about the age of onset, we can group the patients in two groups. One is 15 to 30 years group and the other group is 60 to 80 years group. And when we talk about the male-female ratio, when in the ulcerative colitis is about 1:1 ratio, and in CD, that is Crohn's disease, it is somewhat higher in males. The incidence is somewhat higher in males, that is about 1.1 to 1.8:1 ratio. And this also mainly, the prevalence is mainly in the urban areas and also in high socio-economic class of group. When we talk about the etiology, a single etiology cannot be confine this disease. It is a multifactorial disorder, so there will be different factors which leads to these diseases. They are family history, genetic factors, environmental factors, diet, drugs, infection and immunological factors. Out of this, immunological factor is most commonly seen factor for this disorder, but it may be associated with some other factors which I already have seen. So in family history, when the chance is higher in first degree relatives, when the father is having, then the child also may have a chance for developing 10%, but when both parents are affected, then there is a chance for 36%. And also in twins, monozygotic and dizygotic twins, so there is a higher chance for develop these diseases. Then genetic factors, there are some genetic traits or genetic disorders which may be associated with the inflammatory bowel disease. Out of that, first one is a loss of function or mutation in CARD15, that is caspase associated recruitment domain containing protein 15, which the gene is seen in the chromosome 16. When there is a defect in that, or when there is a mutation in this gene, there is a chance for 10% risk of developing Crohn's disease. And other two genetic factors are polymorphism in interleukin 23 receptor and also in Turner syndrome. Environmental factors here, the cigarette smoking. Ulcerative colitis is about 40%, and in Crohn's disease it can increase, the risk can be increased by twofold. And when talking about diet, increased consumption of mono unsaturated and saturated fats, long chain omega-3 fatty acids also increases the chance for this type of diseases. And in drugs, oral contraceptives and NSAIDs, there are chance for developing these diseases, and some infections like Salmonella, Shigella, Campylobacter, Clostridium difficile, bacteroides, Clostridia, E. coli triggered inflammatory responses. These all are some factors which can lead to inflammatory bowel diseases. But the immunological factor is somewhat common or confirmed factor for developing inflammatory bowel diseases. In Crohn's disease, there will be increased interleukin 1-2 or interleukin 12 in mucosas, increased Th1 response, increased interferon gamma response, increased macrophage activity which activate the matrix metalloproteinases. And in ulcerative colitis, there is increased expression of interleukin 5 beta cell mediated antibody responses. So these all are responses which increases the immunological activity in our body. Okay, so these all are expressions or all these factors or mediators of our immune responses. So this can be seen in this type of diseases, Crohn's disease and ulcerative disease, colitis. Now clinical features. One more thing, the clinic, even though the symptoms are somewhat similar, there is some difference in the presentation of Crohn's disease and ulcerative colitis, and there is some difference in the pathological features, and there is some difference in gross and specimen features of both diseases. These all will be discussed, mainly discussed in your pathology classes, but I am just mentioning the cardinal clinical features. When coming to the ulcerative colitis, the patients will be having diarrhea. It can be nocturnal or postprandial diarrhea, rectal bleeding, tenesmus, passage of mucus, and crampy abdominal pain. So the common symptoms of ulcerative colitis are anorexia, nausea, vomiting, fever, and weight loss. And in Crohn's disease, the symptoms will be mainly associated to the region of the disease. And one more thing, the ulcerative colitis is mainly confined to the colon, the regions of colon. But Crohn's disease, it has got skip lesions. The lesions can be seen from our mouth to our anal region. So in between, anywhere we can see the Crohn's disease, or the pathology can be seen anywhere in this path. So the symptoms also will be according to the area. So when it is affected the esophagus, the symptoms will be dysphagia, odonophagia, heartburns. When it is in duodenum, there will be abdominal pain, nausea, vomiting, weight loss, and hematemesis. Ileocolic region, it is rectal bleeding, fistula, intestinal obstruction. When it is in colon, it will be megacolon, intra-intestinal manifestations, and skin tags, fissures, and perianal scarring, which is seen in the anal region. So the symptoms will be according to the area which is affected. But both of the diseases are mainly seen in the colon or ileocolon regions. And the main symptom will be abdominal pain and diarrhea. So the abdominal pain and diarrhea will be seen in Crohn's disease. And as it is a immunological response or immunological disorder, the same immunological response can be seen in the all over the body. So there will be extra intestinal manifestation. Both these diseases, ulcerative colitis and Crohn's disease, will be having extra intestinal manifestations. There will be dermatological manifestations, will be there, ocular manifestations, rheumatological, hepatobiliary, urological, metabolic bone disorders, and thromboembolic disorders. So as it is an immunological response, the response cannot be confined to that region, confined to the intestinal region. It can goes to some other region through our blood and causes immunological response there also. Okay, this is just a cardinal features of the clinical and pathological region. So it will be discussed in your pathological classes, and I have just summarized that features. Now we will move to our main topic. It is the drugs for the treatment. So the classification of drugs. First group is aminosalicylate. Aminosalicylate, mainly sulfasalicin, balsalicin, and olsalicin. Sulfasalicin, balsalicin, and olsalicin. Next group is steroids, hydrocortisone and prednisolone. There are different types of steroids out there, but here we are using hydrocortisone and prednisolone. Immunosuppressants. Immunosuppressants out of that, purine analogs like azathioprine, 6-mercaptopurine, methotrexate, and cyclosporine. Okay, these all are immunosuppressants. And monoclonal antibodies, infliximab, adalimumab, certolizumab, and natalizumab. These all are monoclonal antibodies. So 4 groups of drug are mainly used in treating inflammatory bowel diseases. First group, aminosalicylate. The action is mainly topical. They act topically on diseased GI mucosa. So they act topically on diseased mucosa. So it has to be given orally. Okay, you have to reach that region orally or rectally. So anyway, you have to reach topically or to act topically. So first group of drug is azo compounds. Azo means nitrogen double bond nitrogen. Okay, nitrogen double bond nitrogen. It is the azo compound. In that, sulfur salicin, bal salicin and old salicin. Another group is mesalamine compounds. Mesalamine compounds. They are pentasa, asacol, rovasa and canasa. Now in detail of azo compounds. 5-ASA compounds by azo bond to a inert compound or other 5-ASA molecule. So the 5-ASA is the active component in the azo compounds, amino salicylate 5-ASA. So it has to be attached to a inert compound or another 5-ASA. Okay. The 5-ASA plus 5-ASA, 2 5-ASA will forms all salicin. 5-ASA plus sulfur pyridine forms sulfur salicin. 5-ASA plus 4-amino benzoyl beta alanine leads to bal salicide. Okay. Why they are combining? So mainly to reduce the absorption of parent drug from small intestine. And these azo compounds has an important mechanism or important pharmacokinetics that they are mainly absorbed or they can be increasingly absorbed from our small intestine. So the main pathology is in the large intestine or in the colon. So the drug has to be reached there. Okay. For that we have to prevent or reduce the absorption in the small intestine and we have to reach the drug in the colon. So we are combining it with an inert or another 5-ASA. And also in the terminal ileum and colon, bacteria cleaves the azo bond by azo reductase enzyme and they will release the active 5-ASA from that molecule. This is the main mechanism. Then mesalamine compounds, pentasa, asacol, rovasa and canasa. They are in pentasa, it is a timed release microgranule that release 5-ASA throughout the small intestine. So it will be the microgranules will be released in the small intestine. In asacol, it is a 5-ASA coated in pH sensitive resins that dissolves at pH of 7. So it will not be dissolved in the stomach or in the duodenum or initial part of the intestine. It will be released in the large intestine. Next is rovasa, enema formulation that deliver 5-ASA to rectum and sigmoid colon. So it is a enema preparation. Another, the canasa is a suppository. One is liquid formulation, the other one is solid formulation. So the canasa is a suppository which delivers 5-ASA to the rectum and the sigmoid colon. The mechanism is they modulate inflammatory mediators derived from cyclooxygenase and lipoxygenase pathway. So the inflammatory mediators which are originated by the cyclooxygenase pathway and lipoxygenase pathway will be inhibited by these drugs. They interfere with the production of inflammatory cytokines, inhibit the activity of nuclear factor kappa B, NFK beta or kappa beta. They also inhibit the cellular functions of NK cells, natural killer cells, mucosal lymphocytes and macrophages. So these all are the inflammatory mediators. It will be reduced by these drugs. And also scavenges the reactive O2 metabolite. O2 metabolite will be a free radical. So that reactive free radical will be scavenged or killed by these mechanisms. Now the pharmacokinetics. The 5-ASA is readily absorbed from the small intestine, which I have told earlier. The absorption is low in the colon. So to overcome this problem, we are adding some other inert substance to 5-ASA to reach the drug to colon. And the N-acetylation in the gut epithelium and also in the liver. So the metabolism is somewhat in the liver and also in gut. And the acetylated metabolite is excreted through kidney. 85% of skeletal molecule sulfur pyridine absorbs from the colon and metabolic metabolism followed by renal excretion. So finally the excretion is mainly by the kidney and the metabolism is mainly in the liver. Clinical use, it is the first line agent to the mild to moderate ulcerative colitis. We can use these amino compounds. It can be used for the induction and also maintenance of remission. For induction, sulfur salicin 1 gram 6th hourly or bal salicin 2.25 grams TDS. For maintenance, reduced dose, so sulfur salicin 1 gram BD or bal salicin 1.5 gram BD. The 5-ASA suppositories and enemas can be used when the ulcerative colitis or Crohn's disease is confined to rectum or distal colon. So when the disease is in the distal colon or in the rectum, we don't need to pass all the area from the stomach to reach the colon. We can directly give to the colon or rectum by suppository or enema. And this also has got some adverse reactions. They are nausea, malaise, GI upset, headache, arthralgia and myalgia. These all are common. And bone marrow depression is there. Hypersensitivity reaction, which can be seen like fever, anemia, exfoliative dermatitis, oligospermia, impaired folate absorption, interstitial nephritis, and secondary diarrhea, all salicin, mainly seen in all salicin. Next group of drug is glucocorticoid. There are different types of glucocorticoids. Out of that, prednisolone and hydrocortisone is commonly used. Prednisolone is commonly used as oral glucocorticoid. So, out of these two, prednisolone is given orally, the other one is used as enema forms or suppositories for topical treatment. And budesonide, a synthetic analog of prednisolone, is also used as a controlled release oral formulation. And the response appears within 2 weeks. So, when we start the treatment, it takes 2 weeks for the response. Mechanism is, again, the mechanism will be suppressing the immune activities, mainly by 3 mechanisms. They inhibit the production of inflammatory cytokines like TNF alpha, interleukin 1, and also chemokines, interleukin 8. Reduces the expression of inflammatory cells adhesion molecules. So, they inhibit the production, they will reduces the expression of that already produced cytokines, and also inhibit the gene transcription for nucleic acid, nitric oxide synthase, phospholipase A2, COX2, and NFK beta or nuclear factor kappa B. So, this is the main mechanisms of glucocorticoids. The clinical use mainly used in moderate to severe active IBD. So, moderate to severe active IBD. So, mild cases we don't want to use glucocorticoids, and the symptoms is moderate to severe, we can use glucocorticoids. Prednisolone initial dose is 40 to 60 milligram per day, and after remission has occurred, we have to taper the dose and continue to a 6 to 8 weeks. When it is given rectally, like suppository or enema or forms, when it is confirmed to the rectum or sigmoid colon. Budesonide, it is also again used in mild to moderate Crohn's disease involving the ileum and proximal colon. When the dose of budesonide is 9 milligram per day into 12 weeks. Here again it has got many adverse reactions. Out of this, the edema, hypokalemia, hypertension, these all are common, and when in chronic use, it can lead to osteoporosis, osteonecrosis. Hyperglycemia and glucosuria is also common for the normal use. The cataract, glaucoma, peptic ulcer, myopathies, and susceptibility to the infections. These all can be seen with the use of these glucocorticoids. Next group, our immunosuppressants. Out of that, purine analogs, thiopurine and 6-mercaptopurine. It is 6-MP. Okay. So, the thiopurine is converted to 6-MP. Thiopurine, after absorption, will forms the 6-MP, and out of that, a few amount will be metabolized by xanthine oxidase or thiopurine methyl transferase, and the rest will follow the anabolic pathway, which will have this anti-inflammatory activity. It will activate thioguanine nucleotide. They will inhibit the immune responses. The use is, it can mainly used in maintenance of remission of ulcerative colitis and Crohn's disease. So, it cannot be used for induction. So, because as it takes so many time, more than glucocorticoids, it takes 2 weeks for response. Here it takes more than 2 weeks for the response. So, it cannot be used for induction, but maintenance it can be used. The dose is azathioprine 2.5 milligram per kg per day, when 6-mercaptopurine is 1.5 milligram per kg per day. Here also there are some adverse reactions: nausea, vomiting, bone marrow depression, anemia, macrocytosis, hypersensitivity reactions, and hepatic toxicity. The next important immunosuppressant is methotrexate. Methotrexate is an anti-metabolite, it is an anti-cancer drug, and it has got many properties. Out of that, immunosuppression is a important property. And the mechanism of immunosuppression are They inhibit the dihydrofolate reductase and inhibit the folate pathway. They interfere in the inflammatory actions of interleukin 1. They stimulate the increased release of adenosine, and also they stimulate the apoptosis and death of activated T lymphocytes. So the activated T lymphocytes and interleukin 1 are the main mediators of inflammatory responses. So it will be inhibited by our methotrexate, and also it has got an inhibitory property on folic acid synthesis. They are mainly used in induction and also in maintenance of the remission. In Crohn's disease, the dose is 15-25 mg once weekly by sub-Q or IM injections. IM injections are most common because sub-Q injection is somewhat most costly. And the adverse reactions of methotrexate are bone marrow depression, megaloblastic anemia, alopecia, and mucositis. This is also common for methotrexate. Next important immunosuppressant is cyclosporine. So they are mainly used in severe situations. The mechanism is there is a pronounced suppression of pro-inflammatory transcription factors. Induce remission in severe ulcerative colitis which is unresponsive to glucocorticoids. So severe ulcerative colitis unresponsive to corticosteroids. The dose is 2 to 4 mg per kg per day IV until remission. Here also there are adverse reactions: nephrotoxicity, neurotoxicity, hepatotoxicity, hypertension, hyperuricemia, and also hirsutism and gingival hyperplasia. So these all are common adverse effects of cyclosporine. Okay, and cyclosporine is a last resort of drug. It can be used only in severe cases and which is unresponsive to corticosteroid. Last group is anti-inflammatory therapy. Anti-TNF factor, that is tumor necrosis factor. Mainly our monoclonal antibodies: infliximab, adalimumab, certolizumab. Infliximab and adalimumab is IgG subclass. Certolizumab is a recombinant antibody which contains the Fag fragment of conjugated polyethylene glycol but lack the Fc portion. So immunoglobulin, structure of immunoglobulin. The mechanism is they binds to soluble and membrane bound TNF, tumor necrosis factor. So tumor necrosis factor, they will bind to tumor necrosis factor and prevent the TNF factor, the tumor necrosis factor, from binding to receptors. So TNF will not be binded to receptors, so inhibiting the response mediated by this TNF, that is antibody mediated apoptosis, complementary activation, cellular cytotoxicity of T lymphocytes and macrophages. This is the activity of TNF mediated by TNF. So that the TNF binding is inhibited. So these all actions will be inhibited. Clinical use can be used in acute and chronic cases of moderate to severe chronic Crohn's disease or ulcerative colitis. The dose of infliximab is 5 to 10 mg IV infusion on 0, then second week and 6th week. So only 3 doses: 0, 2 and 6 weeks. When coming to adalimumab, it is 160 mg or 80 mg or 40 mg according to the symptoms at 0, 2 and 4 week given subcutaneous. Certolizumab, it is 40 mg sub-Q at 0, 2 and 4 weeks. So only weekly once injection, and it is a gap of 2 weeks. Okay, but they have got adverse reactions, infusion reactions, mainly the IV compound. It is fever, headache, dizziness, urticaria and hypotension. Infections, as it is given IV or sub-Q injection, there is a chance for infection like bacterial sepsis, TB, upper respiratory tract infections, cellulitis, invasive infection, fungal infections, reactivation of hepatitis B, and activation of anti-nuclear antibodies, anti-double stranded DNAs, which will precipitate SLE like symptoms, delayed serum sickness reactions, lupus like syndromes, and also it can lead to acute hepatic failure, demyelinating disorders and hematological infections. And the last group is anti-integrin therapy, natalizumab. So it is the anti-integrin therapy. All other was antibody, TNF, tumor necrosis factor. Here it is integrin. So it is the Natalizumab is a humanized IgG4 monoclonal antibody against alpha 4 subunit of integrin. So integrin has got a alpha 4 subunit, and our natalizumab act on this alpha 4 subunit of integrin. So what is integrin? Integrin is a family of adhesion molecules on the surface of leukocytes that interact with another cells of adhesion molecule on surface of vascular endothelium known as selectin. So there is a vascular endothelium is there is a substance called selectin, and the other group there is a leukocyte which has got a adhesion surface known as integrin. So this two, integrin and selectin, should be attached, which allows, when these both two of them attaches, it allows circulating leukocyte to adhere to the vascular molecule. So only when these two are attached, only the leukocytes can attach on the endothelium. But the natalizumab will prevent the attachment of these two factors, okay, and reduces the inflammation. So it blocks the integrin and prevent binding of vascular adhesion molecules and migration of tissues. So it helps to prevent the spreading of our inflammation. So if there is one region is having some inflammatory responses, and this can be spread through our leukocytes, through our blood to some other areas, and attachment to the endothelium of somewhere place can lead to inflammation there also. So this will prevent that adhesion of our leukocytes and inhibit the immunological response. Again, used in moderate and severe Crohn's disease, 300 milligram every 4th week by IV infusions. So adverse reactions like infusion reaction is there, multifocal leukoencephalopathy is there, and opportunistic infections. Okay, so that's all the drugs for inflammatory bowel diseases. All the inflammatory, as I've told, the inflammatory bowel diseases are some sort of inflammatory disorder, or autoimmune or auto-mediated inflammatory responses. So there will be abnormal responses, inflammatory responses all over in our body. So the main treatment modality is stopping the inflammatory response, or the factors, or modifying the factors which responds for inflammatory response in our body. So all the drugs which we already discussed, all of them, the major or the main mechanism is inhibiting inflammatory response, the abnormal inflammatory response. Okay, when the coming to our treatment of the patients, there is a pyramidal like approach. That means the mild, we will be, when the case is mild, we will have some sort of drugs. When it becomes moderate, we will add on some more drugs. When it goes to severe, again we will add on, or we will use the severe or last sort of drugs. In detail, as here in the figure, in the mild case, we can see the drugs used are budesonide and topical corticosteroids, antibiotics, and 5-aminosalicylate. So these all are some sort mild drugs. When the disease is moderate, we have to use, again we will go for oral drugs, TNF alpha, oral corticosteroids, TNF alpha antagonist, methotrexate, azathioprine, 6-mercaptopurine. Even though these are the effective drugs, they all have some sort of higher chances for adverse reactions and morbidities associated with each group. When the disease is severe, again we will use the last group of drugs, natalizumab, cyclosporine, again TNF alpha antagonist, intravenous corticosteroids. Here we are using oral corticosteroids. First group we are using topical corticosteroids, mainly by our enema or suppository. When it is moderate, we go for oral corticosteroids. When it is severe, we have to use intravenous corticosteroids. And also surgery, when the disease is confirmed, or when the disease has caused some obstruction and all, then there is no role for the medical treatment. We will have to cut that part, and we have to re-anastomose that area. So surgery will be needed in severe cases or refractory cases. So in the natalizumab and cyclosporine, all are the last sort of drugs which will be used when the disease is severe, and it is very refractory diseases. Okay, and that's all. Completed our inflammatory drugs used in inflammatory bowel disease. Hope all of you will read the concerned topic in your textbook, and also you have to attend the MCQ online quiz in your Google Classroom. Hope all of you are safe at your home. Stay home, stay safe. Thank you. With regards, Dr. Rahul. Thank you.